You're welcome to this session. Our topic is Vulva Intra Epithelia Lesions. My name is Adegboyega Fawole. I'm a professor and honorary consultant, Department of Obstetrics and Gynecology, University of Ilorin, and the University of Ilorin Teaching Hospital, Ilorin, Nigeria. Our learning objectives for this topic include: we will show the relationship of pre-malignant lesions to invasive carcinoma. These lesions, though with low malignancy potential, need to be given strong attention. Some lesions need treatment to prevent them from progressing into invasive carcinoma. At the end of the lecture, it is expected that the listener will be able to know the difference between the pre-malignant and malignant lesions of the vulva and vagina, and appreciate the importance of looking out for pre-malignant lesions of the vulva and vagina. We all know that vulvar cancer is common, accounting for about 2 to 5% of gynecological malignancies. Squamous cell carcinoma of the vulva is the most common and is the most common subtype. It has been traditionally regarded as a disease of the post-menopausal women, although the mean age of incidence has fallen in recent times, owing to the increasing in incidence of the human papilloma virus infections worldwide. So, there are two main pathological pathways that lead to vulvar squamous cell carcinoma. The first is the keratinizing squamous cell, usually occurring in older women, and is often associated with lichen sclerosis and now of differentiated vulva intra epithelia neoplasia. The other one that we are more concerned about is the warty basaloid squamous cell carcinoma, generally that is occurring in younger women. It is caused by persistent infection with oncogenic strains of the human papilloma virus, particularly strains 16, 18, 31, and 33, and has the squamous intraepithelial lesion as its precursor. Lesions are frequently multifocal and may be associated with squamous intraepithelial lesion in other parts of the lower genital tract, e.g. cervix, vagina, and anus. The human immunodeficiency virus infection and cigarette smoking are also common predisposing factors. The terminology and definitions of the pre-malignant or precursor lesions of vulvar cancer have been reviewed and changed in the last decades. Currently, such lesions arising from the vulva and the anus are all included and are named as lower anogenital squamous intraepithelial lesions. Under this classification, 3 subgroups are distinguished for the vulva: low-grade squamous intraepithelial lesions, high-grade squamous intraepithelial lesions, and the differentiated variant. Such distinction correlates with the risk of developing cancer over time. The table here shows the vulva intraepithelial neoplasia terminology changes in 1986 and in 2001. VIN1, VIN2, and 3 have become, VIN1 has become low squamous intraepithelial lesion. VIN2 and VIN3 have become high-grade squamous intraepithelial lesion. And the differentiated vein has become the differentiated vulva intraepithelial lesion. These are sources from you could see below. The pathology of the squamous intraepithelial lesion may be that the lesion may be single or multiple, may be macular, papular, or plaque-like. Histological grades are labeled low-grade squamous epithelial lesion, which is VIN1, corresponding to mild dysplasia, and high-grade squamous epithelial lesion, labeled as VIN2 to 3, corresponding to moderate and severe dysplasia respectively. The high-grade squamous intraepithelial lesion, which includes squamous cell carcinoma in situ, is by far the most common. Most tumors are exophytic, but may be ulcerative. Microscopically, the tumor is composed of invasive nests of malignant squamous epithelium with central keratin pelts. To date, there is no definite treatment for conditions such as lichen sclerosis. Cornerstone measures include avoiding exposure to precipitating factors like trauma by local irritants, occlusive moist environment, and the use of potent and ultra-potent topical corticosteroids. So, the best thing is, how do we prevent this thing from happening so that it doesn't get us into that progression of cervical or vulvar cancer? It has been known that persistent human papillomavirus infection, particularly the HPV-16 subtype, has been associated with long-term development of high-grade squamous intraepithelial lesions and squamous cell carcinoma of the vulva. The introduction of human papillomavirus vaccination as a primary prevention strategy in cervical cancer has been shown to also reduce the prevalence of the non-cervical pre-malignant lesions among the vaccinated women. So these vaccinations are important. Secondary prevention. There's no evidence for screening is important. There's no evidence for specific screening. Self-examination in women with lichen sclerosis, a condition related to vulvar cancer development, should be encouraged. In addition, there should be early evaluation of any patient with signs, pigmented lesions, irregular ulcers, chronic vulvar pruritus, commonly associated with this vulvar disease. They should then decide on who to have skin biopsy. Tertiary management, of course, we call effective strategy to reduce vulvar cancer incidence at the opportune time, so we can treat this predisposing and pre-neoplastic lesions associated with vulvar cancer development. Finally, women who are known to have squamous intraepithelial lesions of the cervix, vagina, and anus should have inspection of the vulva as part of their follow-up and colposcopy. Multiple treatment modalities exist for the management of the high cell, but simple excision of the margins with 5 mm margin and 4 mm depth is the most common. Excision has the advantage of excluding invasion histologically, but the lack of preservation of vulvar skin results in psychosexual morbidity, particularly in the younger women. An alternative option is to preserve anatomy is to use carbon dioxide laser, but this lacks the assessment of occult invasion. A less destructive lesion is the use of imiquimod, 5% to avoid scarring and sexual dysfunction, particularly in small lesions. Moderate quality evidence shows that the response rates with imiquimod and cidofovir, another topical agent, are similar at 6 months compared with surgical management or laser vaporization. Alternative options include the use of topical calcineurin inhibitors, tacrolimus, or retinoids, and photodynamic therapy for selected cases and/or cases that are resistant to corticosteroid therapy. In women, surgery is restricted to scarring processes, leading to functional impairment. There is very little evidence of the effectiveness of topical treatment for high cell among immunocompressed women. These are all special people. Independent chosen treatment and margin status, there's a risk of recurrence of up to 30 to 40%. Therefore, a close follow-up is recommended in these women for at least 2 to 3 years. We must mention before we go Paget's disease of the vulva, which is the high-grade squamous nephrotic neoplasia. It is rare, but it can affect the apocrine glands of the vulva. There are 2 types. The primary one that begins as an intra epithelial lesion, and the secondary one that begins as an underlying adenocarcinoma, which may be endorectal, urothelial, or genital tract carcinoma. We are concerned with the intra epithelial lesion. Vulvar Paget disease occurs predominantly in postmenopausal women who present with vulvar pruritus and pain on examination. An eczematoid weeping lesion is often seen. Diagnosis is usually confirmed by biopsy, which will also help to differentiate between an intraepithelial and an invasive lesion. The treatment of choice for intraepithelial Paget disease is wide local excision. It is challenging to achieve wide clear margins. Histological changes often extend beyond what is visible macroscopically. Even with adequate margins, recurrent rates are high. Due to these high recurrent rates and surgical morbidity, there is a current move to perform less radical resection for intraepithelial lesions with re-excision at a later date if lesions occur. However, lesions involving urethra, anus, also present with a management challenge. They require laser therapy. Another conservative treatment option is imiquimod. A Cochrane meta-analysis that investigated treatment options concluded that there was no best intervention for vulvar Paget disease. If an underlying adenocarcinoma is present, treatment should be radical wide local excision with margins of at least 1 cm inguinofemoral. Inguinofemoral lymphadenopathy should be performed with adjuvant radiation for the same indications as we have for squamous carcinomas. An evident picture of Paget's disease for our interest is on the right labial, and it goes extensively, almost extending the whole of the perineum and getting near to the anus. This is also carcinoma in situ, which is a progression of Paget's disease at this time. It's Vulva Intra Epithelia Neoplasia, grade 3. Our references are FIGO Cancer Report 2018, Berex and Novus Gynecology, 16th edition, PDF. Thank you very much for listening.